Oh, hey, we're so glad you could join us for the day here at Quality Improvement. I'm just going to check my email really quick, and then we can see if there's anything for you to do today. Oh, looks like I just received an email from a nurse manager asking for us to check out a case. Okay, so she says, "Good afternoon. There is a case from Psych 5 North that I was wondering if you could look over. The patient's name is Bridget Robinson. I'm concerned that there might be some room for improvement regarding the care she received. She was a new admission on July 1 due to a panic attack. She was seen by Dr. Aurora Holden throughout her stay. Miss Robinson ended up staying later than the initial clinical pathway indicated she should, and I would like to see if there is a way we can avoid this for future patients. She was discharged this morning." Well, all right, perfect timing. Let's take a look at Miss Robinson's stay. All right, so some initial information that I found on her chart. Her name is Bridget L. Robinson, born 5/20, 1996, a white female with no known allergies. Her chief complaint was a suspected panic attack. Her code status is presumed full, and she has no health history or current medications. All right, so in her chart on day one at 15:35, it says there is a report from the paramedics. Patient was found in her home after calling 911. Initial assessment found that she was hyperventilating, had a bounding pulse, was tachycardic and diaphoretic, appeared to be choking, was crying and restless. We demonstrated pursed lip breathing for her to attempt to calm down. Paramedic advised her to close her eyes and focus on her breathing. IV access initiated. EKG leads were placed on the patient. Patient reported increased chest pain, level 9 out of 10. Diazepam given as documented. Team loaded patient into ambulance and headed to the hospital. Patient never lost consciousness. Some vital signs I found that were from the ambulance. Her heart rate was 184. Her respiratory rate was 74. Blood pressure 172 over 104. 99.3 for the temp. 95% for oxygen saturation. Her lung sounds were clear bilaterally. She was tachypnic and her lung sounds were shallow. So that's what hyperventilating typically sounds like. Her EKG reading was sinus tachycardia. Additional findings: the patient stated her symptoms, quote, started about an hour ago by the time paramedics arrived. The medications they administered per the MAR was diazepam 5 milligrams, IV push stat over 1 minute. All right, so the patient was described by the paramedics as being found hyperventilating. What ABG values would you expect for this situation? So feel free to take a look and then we will figure out the answer together. All right, so the answer is B. The pH is high, so it points to alkalosis, and the PCO2 is lower than the reference range, indicating respiratory involvement. So she is suffering from respiratory alkalosis. So again, on mission day one, I found another note at 16:02 from the ED nurse. Patient came into ED via ambulance and stretcher, received SBAR report from paramedic, patient A&O times 4, admission assessment found that she was crying, tachypnic, warm to the touch, nasally congested, irritable and fatigued. Patient complained of heartburn, muscle aches, and chest pain. Patient pain rated a 6 out of 10. Medicated as documented, 12 lead EKG administered, findings found as charted, labs drawn and sent, provider notified, patient left in triage with call bell within reach and bed in the lowest lock position. So again, they got her vital signs. This is at the hospital. Her heart rate was 104, respiratory rate 30, blood pressure 135 over 96, temp 99.3, oxygen saturation 99%. Her lung sounds were clear bilaterally, and she was tachypnic, and she had sinus tachycardia reading on the EKG. Additional findings: the patient stated she, quote, experiences these episodes sometimes, but none have gotten this bad before. And per the MARSH, they administered aspirin 81 milligrams by mouth stat. All right, so taking a look deeper into this, what additional labs and diagnostic tests or screenings could be expected for this client based on the symptoms identified? All right, so they might do a CBC and CMP, troponins, blood glucose test, urinalysis, and pregnancy test. So all of these are typically rule out information as well as to get an idea of what's going on within the body. So they want to rule out anything cardiac involvement. They might do a depression screening or an anxiety screening. And the diagnostics, they will definitely get a family and personal medical history. They'll get a detailed head to toe assessment for baseline, a CT scan, and a chest x ray, checking for abnormalities. All right, so day one lab results, 1633. Everything looks pretty on par. She had no HCG in her blood. Her troponin level was great. Her blood glucose level was 76. Looks like her RBCs, white blood cells, platelets, hematocrit, everything looks pretty great. Pretty on par with what we want. All right, so I also found access to her generalized anxiety disorder screening. So if you look at the document on the left, it will indicate that she scored a total of 18 points and said that her symptoms started at 18 years old. If you look at the document on the right, severe anxiety is indicated from her score of 18. All right, so additional information I found for day one. At 1729, the patient was moved to Psych 5 North, room 15N. There was a nursing note from the psych nurse. Received SBAR from Lauren RN. Patient admitted to psych floor for observation. Patient ANO times 4. No signs of distress noted. No signs of anxiety at this time. Admission teaching provided. Shift assessment completed as charted. Patient is drowsy and irritable. Pain rated a 2 out of 10. Provider notified of admission. Call bell within reach. Bed in lowest lock position. There was also an additional note from Aurora Holden, MD. She is the psychiatrist who was on call that time. She received SBAR from Katrina RN. Assessment findings include irritability, confusion, drowsiness, and inability to focus. Anxiety screening reviewed. Spoke with the client regarding results. Patient indicates her feelings have been going on since she, quote, was 18 years old and have been manageable until now. New medication orders available. Will continue to monitor. Discharge likely tomorrow, which would be the 2nd of July. She also put in an official diagnosis of generalized anxiety disorder. So there was also an additional nursing note from the psych nurse that she administered buspirone per order. So that's great. All right, so Miss Robinson has just been prescribed buspirone. What are some of the possible complications to watch out for? So you want to definitely check for suicidal thoughts, blurry vision, chest pain, seizures, migraine, shortness of breath, muscle weakness, and skin rash and hives. Buspirone is an anti-anxiety medication. It works directly on the brain, and the possible side effects that could follow could be related to neurological status. Like any medication, a patient can be allergic to it and have serious consequences due to the allergy. So day two, I found some information from 0951. This is her next day of her stay. There is a nursing note from the psych nurse saying patient is calm, withdrawn, and quiet with little desire to eat or get out of bed. Patient rates pain a 0 out of 10. Medications administered per order. Assessment findings as charted. Patient desires to be left alone, but she consented to a vitals check. Bed left in lowest lock position with call bell within reach. There was also an additional note from Aurora Holden, MD. So that is again the psychiatrist. Assessed patient. Findings indicate withdrawn and apathetic behavior. Nutrition is noted as poor. Hygiene beginning to diminish. Impending discharge discussed. Patient demeanor was unchanged. Will continue to monitor. New order for propranolol placed. So at this point in time, the current medication orders for this one patient was buspirone, diazepam, and propranolol, and that diazepam is only for nightly. The vital signs per this time was heart rate 70, respiratory rate 13, blood pressure 114 over 75, temp 98.9, and oxygen saturation 99%. So it's completely different from day one. There were additional notes from the psych nurse at 1445. Patient shared suicidal thoughts from the nurse. The patient said, I quote, I just can't take this anymore. Is this what my life has come to? Pills, stress, and unhappiness. Everything would be so much easier if I just wasn't here anymore. Okay, so that is a big turn. Patient identified a detailed suicide plan. Patient's plan indicates cutting her wrists with a blade. Thorough check done of the patient and room. No obvious weapons found. Provider notified immediately. Request for a one-to-one sitter placed. Amber CNA placed in room until sitter arrives. Depression screening administered. Finding is charted. Patient denies physical pain at this time. Okay, so definitely we should have done that depression screening a little bit earlier, probably on admission if we did the anxiety screening as well. So then the note from the psychiatrist said, SBAR received from Breyer RN, patient assessed, thoughts of suicide present, personal plan in place, signs of agitation present, CNA identified as current sitter, security notified, restraint order placed, PRN per protocol, new diet order placed, therapy consult placed, new order for a urinalysis, patient given additional dose of diazepam for agitation, patient safe at this time, will continue to monitor, withdrawal of discharge orders. Okay, so that urinalysis definitely should have been done on admission as well, and you can see they withdrew their discharge orders. So in the psychiatrist's note, she mentioned a new diet order for the patient. So why is this detail important for this particular patient? Well, patients at risk for self-harm need to be monitored to ensure they do not gain access to weapons. The term weapons can refer to just about anything. Lunch trays can be used as such, and some patients might even try to use the utensils as weapons as well. Their food options should be safe, so finger foods are typically the chosen route, but will also need to be nutritious. So a perfect example would be a handheld fruit, or maybe like a granola bar. All right, so on day 2 at 1450, I found the personal health questionnaire, which is the depression screening. So if you look on the document on the left, it looks like she scored a 17 and also indicated that she's been feeling this way since she was 18 years old. And on the right, you can see the 17 score falls in the moderately severe depression range. All right, so there is a new note from Reagan Mims, LMHC, which is licensed mental health counselor. So she's the therapist. New patient assessed, shares thoughts of harming herself, describes detailed plan, expresses desire to sleep with anxious tendencies, including jitteriness and psychomotor agitation. No weapons found in room, confirmed dietary change, patient safe, recommendation of CBT to start immediately, patient willing to participate, individual session started, describes history of strict household, peer-to-peer bullying, and sexual assaults, maternal history of psychiatric disorders, next session scheduled for tomorrow at 09:30, and she entered a new depression diagnosis. So then the psych nurse wrote a note saying that therapist just left the patient with the one-to-one sitter, patient settling into sleep, patient quiet, vital signs stable, patient states their physical pain is a 0 out of 10, no signs of distress noted at this time, educated the client to use her call bell if she needs help, additional labs drawn, no negative encounters during lab draw or blood draw, no need for restraints at this time. So in the therapist's note, she mentions CBT. What does this mean and why did she recommend it for the patient? CBT stands for Cognitive Behavioral Therapy. It's the most commonly used form of therapy for those with mental health disorders. It focuses on driving deeper into the patient's thoughts and discovering the whys behind them. They will also practice goal setting, experience cognitive conditioning, and have homework assignments to keep them engaged. So why did the psychiatrist put in an order for a urinalysis? Substance abuse is common for those suffering from a mental illness. Even though she is in the hospital, she can still gain access to harmful substances. This also sets a baseline for her future care. Medications and illegal drugs can be identified in the urine. They have the potential to worsen anxiety depending on the drug found. All right, so that urinalysis definitely should have been done on admission, not day 2. So these are her results that I found that were logged at 1543. Blood glucose looks great. She came with her urinalysis is free and negative of the substances that we checked for, and her CMP looks perfect. All right, and then I saw on day 2 at 2031 diazepam was administered per order. All right, so I looked through day 3 and day 4, didn't really find much going on, but day 5, 0843, there's a nursing note from the psych nurse. SBAR received from Michael RN, patient A&O times 4, no weapons found at this time. Shift assessment completed as charted. Findings indicate positive behaviors like smiling, active listening, asking questions about future care, and proper hygiene. No evidence of anxiety noted, vital signs stable, patient displays no signs of distress, medications given per order, patient safe and left with one-to-one sitter to shower before therapy scheduled at 09:30. And her morning vital signs, her heart rate was 62, her respiratory rate 16, blood pressure 119 over 84, temperature 98.6, oxygen sat 100, lung sounds were clear bilaterally, even and unlabored, and her heart sounds were S1, S2, and normal sinus rhythm. All right, so that is the sound of normal sinus rhythm. And the medications she administered were buspirone and propranolol. So, what is important to monitor for in a patient while they are taking propranolol? Heart rate, blood sugar levels, blood pressure, and allergic reaction. The patient's heart rate should be checked prior to every dose of propranolol. A heart rate of 50 beats per minute or less warrants withholding the dose. Propranolol has been known to mask the symptoms of hypoglycemia. The patient should have their levels checked frequently to ensure their blood glucose is within normal range. Propranolol can lower blood pressure. This means that it has the capability to lower it too much, causing severe hypotension. Patients taking new medications have the possibility of experiencing an allergic reaction to it. All of these are important for the medical staff to monitor for. All right, so on day 5 at 10:35, there was a note from Reagan. Patient group session completed. Patient displayed positive signs of emotional growth and progress towards potential discharge. Patient participated in the group activities and helped fellow group member with the project. Hygiene has improved. No signs of distress or agitation. No suicide contract signed and in place. And there are the lab results that I found that also correlate to day 5. Looks like her labs are pretty beautiful. They also did the creatine kinase, which is a cardiac lab. There's also a note from Aurora Holden, again our psychiatrist. Patient encounter for assessment. Patient requested to go home. Discharge likely tomorrow. Patient responding well to medications ordered. New orders placed to assess cardiac function due to the prescriptions for propranolol and diazepam. All right, so what is a no suicide contract? A no suicide contract is an agreement drawn up by a therapist and signed by the patient. It focuses on the agreement of the patient to seek help if they need it once they are released from the hospital and on their own. It is also a place for a patient to reference it if they end up needing suicide prevention support. The contract usually has additional resources included for the patient's benefit. It also allows for the therapist to break confidentiality if the patient expresses thoughts of self harm and suicide. There is a clear and defined list of individuals the patient gives permission to this therapist to contact in this event. This is especially important for this particular client who has already voiced thoughts of suicide to healthcare personnel. All right, so this is the copy of the no suicide contract created by Reagan Mims and signed by both Reagan Mims and Bridget Robinson, the patient. So the patient was prescribed diazepam. What is the appropriate antidote in the event of the overdose? You need to know this. Flumazenil. Flumazenil is the antidote for benzodiazepines. Diazepam belongs to this class of medications, therefore it will be the required medication in the event of an overdose. All right, so on day 5 at 2014, I found another nursing note. Said patient A&O times 4, patient sitting up in the bed. Patient's heart rate was 87 beats per minute after taking apical pulse for 1 full minute. Diazepam administered per order. Patient tolerated it well. Patient not displaying any signs of anxiety. 4Ps addressed. Bed left in lowest lock position. Call bell working properly and easily accessible. Day 6, I found some more information. This looks like it might be the day of discharge. At 07:56, there's a nursing note from the psych nurse. Receives S-bar from Nicholas RN. Patient was awake and showered already before I entered the room. A&O times 4. Vitals are as charted. Assessment completed and documented. Findings include normal sinus rhythm. Lung sounds clear and unlabored. No signs of distress. No signs of any abrasions or lacerations on skin. And hygiene appropriate for time and place. Patient rates pain as 0 out of 10. Medications administered per order. No additional requests at this time. Room is free from weapons and hazards. Patient received a phone call from her sister as nurse exited the room. They also had administered buspirone and propranolol per the order. The morning vital signs were 71 beats per minute for heart rate, 17 breaths for respiratory rate, 124/81 blood pressure, 98.6 temperature, and 100 oxygen saturation. So why are their nurses charting about the client's hygiene? The patient has been diagnosed with generalized anxiety disorder and depression. These two mental health disorders tend to make the client more prone to disregarding personal care measures, leading to soiled clothing, soiled hair, and personal filth. They can go days without showering, washing their hands, changing their clothing, or even brushing their hair. This leads to worsened self-esteem and potential infections. A positive change in hygiene habits indicates a positive change in the client's mood. All right, so again on day 6 at 10:23, I found a note from Reagan Mims. It said, patient assessed, no signs of distress present. Patient showed signs of emotional growth based on behavior. Patient indicated no thoughts of suicide or self-harm are present. Patient has identified several triggers to our anxiety. During therapy this morning, the patient worked on new coping mechanisms. Patient started journaling thoughts and has made a plan to continue journaling after discharge. Order placed to update for updated GAD-7 and PHQ-9 screenings prior to discharge. Therapy will continue in an outpatient forum. Follow-up therapy appointment has been scheduled. No further need for inpatient monitoring identified. And the psychiatrist wrote, thorough assessment completed on patient. Patient shows no signs of distress. Behavior has changed to a more positive one. Patient believes the, quote, medications are working. No evidence of self-harm noted. No evidence of anxiety noted. Patient does not express any thoughts of suicide or self-harm. New set of labs ordered prior to discharge for new baseline. Patient has agreed to monitor therapy to continue therapy on an outpatient basis. Follow-up required post-discharge. Diazepam ordered still valid. Patient will need to arrive at FTI Behavioral Health for dose for the first 2 weeks. Following this, dosing will be by the patient at home. Referral created for FTI Behavioral Health Psychiatry. No need for additional inpatient monitoring. Discharge orders placed. So why is the psychiatrist having the patient come to the hospital for the diazepam dose for the first 2 weeks following discharge? This is a safety measure put in place to monitor the client while on the medication. Diazepam is typically used for short-term therapy. By having the client come to the hospital for the dose, it's making sure that the patient does not go home immediately after a hospital stay and try to overdose on the medication. It also allows for more time assessing the patient following her hospitalization. So these are the lab results I found at 11:01. Looks like everything is perfect. The urinalysis came back clean. Negative on all of those. Glucose 92, looks like RBCs and everything looks pretty on par. And this is the GAD screening for discharge. She scored an 11, which is better than her original score. It also indicates moderate anxiety. And then the depression screening, I also found she scored a 10, which is way better than her initial one, and that just scores a moderate depression. All right, so before Ms. Robinson discharges, what are some important things to include in her discharge teaching? Information regarding medication administration, safety, dosing, contraindications, and possible adverse effects of the 3 prescriptions she has for buspirone, diazepam, and propranolol should be included. A copy of the signed no suicide contract should be given to the patient if not done so already. Information regarding generalized anxiety disorder should be included, as well as the focus considering it was the initial cause of her hospitalization. The referral information and follow-up dates and locations should also be included in her discharge teaching. So at 11:50, there was a nursing note that said, patient A&O times 4, patient sitting up in bed wearing street clothing, discharge teaching printed and given to the patient, discharge teaching completed and education was reviewed, patient eager to learn information, no questions asked at this time, no signs of distress, patient expressed excitement to go home, no evidence of anxiety noted, accompanied patient to the main lobby, patient had a ride waiting for her downstairs, patient fully discharged with all of her personal belongings. All right. So let's write her an email back to the nurse. Good afternoon, Rebecca. Thank you for bringing this case to our attention. We have reviewed Ms. Robinson's stay in its entirety. After thorough discussion and verifying everything with the latest evidence-based practice, we have found only a few things that can be changed in the future. First, the psychiatrist should put in the order for the urinalysis upon admission. This will ensure the patient has baseline results in the system for the duration of their stay. It could also provide insight into what's going on inside the patient's body. Secondly, the depression screening should be administered alongside the anxiety one. They have several questions that are similar, and this will minimize the work on the nurse's end as well as they will be clustering their care and gaining important information and insight into their patient's state of mind. So thank you for assistance with this, quality improvement team. Well, thank you for helping me look over this case. I really appreciate your help. Look forward to you coming and joining us next time.